When we get into our saphenous testing, so we just kind of concluded the discussion talking about deep vein testing, and we're evaluating for the presence of acute DVT, chronic DVT, and reflux within the deep system for our patients that are here for venous insufficiency. So how I scan, I usually do the deep veins first, and then I move into the saphenous vein, and I don't go back to the deep veins again. So that you can do it either way. My typical approach is I do my DVT study first, and then I start testing my saphenous system. So with our saphenous system, we are looking at our AP diameter measurements as well as checking for reflux. And in our presentation and this conversation we're having, we're going to talk more about AP diameter, and then we'll move into our spectral analysis and the waveforms. But when you're testing, you can do both at the, side by side, where you're measuring your diameter in your high thigh, and then you just turn in sagittal and go ahead and get your waveform information and determine if there's reflux. In this presentation, we break it down by AP diameter first, and then we go into reflux. But I just want to point that out. When I'm testing, I'll just do both at the same time and just move on. You try to avoid going back to the same area again. We have to be very efficient with our time. We have a lot of patients to take care of. So, and these studies take a while. There's a lot of information in them. So, but testing for, the second part of testing is the assessment of the saphenous system. And we are measuring the diameter of the vein, and the typical locations would of course be for this greater saphenous at the saphenous junction, there's a typo there, SFJ, saphenous femoral junction. Then of course our high thigh, above knee, below knee, and calf. Maybe the protocol that you have where you're working, maybe there's a few more locations, or maybe even a few less locations. But the point really is to scan through the saphenous vein to measure the maximum diameter. So I'm looking in my high thigh, and I'm scanning through the high thigh area, and I want to measure the greatest diameter. And then above knee, same. I'm scanning through, and I want to measure the greatest diameter. And maybe I'm not exactly in the high thigh, but this is the greatest diameter in that area. So we want to document the greatest diameter of the saphenous vein in our assessment of the saphenous vein. And scanning through it, this is pretty much the entire leg. This gives us that opportunity to truly assess the entire vein. With our saphenous vein, we are just checking in two locations, the posterior mid-calf and then at the junction. And then we also want to consider the diameter for those large accessory veins and tributaries into the saphenous, because those can cause problems for the patients as well. And we need to make sure that we're definitely measuring the saphenous and not a tributary of the saphenous. So recall with our anatomy, the saphenous is traveling within the eye. It looks like the eye of Cleopatra. So this is what we want to look for, this anatomical sonographic sign that we want to see to call it the saphenous vein. And we measure from AP, we're measuring the wall all the way through to get that greatest diameter. The saphenous vein, typically, again, it runs more medially. There's a lot of different tributaries that are draining into the saphenous vein and then into the deep system and the groin. It can become very confusing with so much in the groin area. It's just important to recall that the saphenous vein is traveling medially, and one of the more prominent vessels that you might see in the area of the saphenous vein that could cause some confusion is the anterior accessory saphenous, or also known as the anterior lateral saphenous. This vessel is running more anteriorly, more anterior to the artery and vein, deep artery and vein, whereas again the saphenous vein is traveling more medially down the leg. And again, we can follow the saphenous all the way through to the medial malleolus. The anterior accessory vein typically remains within the thigh. And we have to remember too that the saphenous vein is in that compartment. Those tributaries, the several different tributaries of the saphenous veins, the tributaries pierce the saphenous compartment, draining into the saphenous vein. And here's an image that demonstrates a tributary, the saphenous vein, the compartment, and then some varicose veins as well. So we really want to make sure that we are measuring the saphenous and calling it the saphenous, and what we are calling the saphenous is truly the saphenous. These studies can often be the roadmap for a treatment for the patient. Your study could determine whether or not the patient is going to receive an ablation, chemical ablation, or heat-induced ablation to treat the symptoms, the disease that's causing these symptoms. So it's important that we're accurate in the information that we provide the reading physician and possibly the treating physician as well. So we definitely need to take the time to follow these vessels and determine which one's a varicose vein, which one's a tributary, which one's a saphenous, and document it. Most places use worksheets and document their findings on the worksheet, and that's a great location to explain your findings. And always, you know, the eye, Cleopatra. And the short saphenous vein, a small saphenous vein, it travels in the small fascial compartment, and this one is referred to as the cat's eye. So it's a little bit smaller. And with the saphenous or short saphenous vein, there could be many variations in where it's draining, whether it's draining into the popliteal or into the femoral. There can be a lot of variations. Usually we note if it is draining into the popliteal or not. Typically, it's, again, depending on where you work, typically we're not looking to see where it drains into. We just make a note of, yes, it's draining into the SPJ, or no, it's not. And we still measure the diameter and we evaluate for reflex too. But again, these veins can be really small, the short saphenous veins, so it can be very difficult to evaluate. For the diagnostic criteria with our publishers, the greater saphenous and at the junction greater than 9 millimeters is highly predictive of valvular incompetence. In the mid-thigh and in the calf area, mid-thigh, if it's greater than 7.5 millimeters, would be predictive of valvular incompetence, and then in the calf would be greater than 5 millimeters. And notice the calf diameter measurement includes the short saphenous or small saphenous vein. Now we're going to talk about spectral analysis and how we use this to evaluate for reflux. This is what we should typically see. We have the flow going in one direction. This is evidence of augmentation. And then we see a little bit of normal valve closure. So the valves are coming together. They're coapting, coming together to prevent blood from flowing back down towards the leg. There is a normal reflux. There's a normal period of time that, you know, a couple of milliseconds, actually 200 to 300 milliseconds for those valves to come together. So with ultrasound, we can see that. We can see evidence of physiological reflux. Here, we see it in our waveform, but we can also see it with color. When we are performing a distal augmentation, we see the rush of blood moving through our vein and through the area of our sample gate, and then, or with color, we see the rush of blood, and then we see the flash of red. That flash of red is just the physiological response, a little bit of reflux, physiological reflux as the valves come together. So that's normal, and that's typically 200 to 300 milliseconds. It's expected. We should see that. We should see evidence of that. When we are evaluating the saphenous system for reflux, we're looking in the same areas as we are measuring the diameter, the AP diameter. So again, we can just do it at the same time. If I'm in the high thigh, I'm doing both. I'm measuring AP diameter, and then I'm moving into my SAG, and I'm going to take my waveform and evaluate for reflux. And we also, again, just as with our AP transverse diameter measurements, I'm also evaluating the varicose veins and the prominent tributaries with the spectral analysis, just as I did with AP diameter measurements. With our short saphenous or small saphenous, again, it can be very difficult to obtain a waveform, much easier to see in transverse than to turn on Sag and take a waveform when they're really small. Sometimes they can be about 1 millimeter in size, 1.5 millimeters in size. It's really difficult to get a waveform. So it depends on your protocol. Perhaps the doctor would be okay with you not wasting so much time on that because it is so small. The Valsalva maneuver is really important to assess the valve function in the groin. It doesn't work for us in the mid to distal or mid lower leg. It's not effective, but in the groin, it's certainly effective, and we definitely want to attempt to use it. Sometimes our patients cannot do it though, so we definitely really need to practice with them, coach them through it. What it's doing though, it's increasing the venous intraluminal pressure in the inferior vena cava, iliac, and common femoral veins. And again, it's testing the valves. So here, the same image we looked at before, the valves are coming together. There's a little bit of a reflex there, physiological reflex, and then the flow stops because the valves are together. They're together because of that increase in venous intraluminal pressure with the patient performing the Valsalva maneuver. And the Valsalva maneuver is with the patient taking a deep breath in. This is what I tell my patients to do. Take a deep breath in, tighten their stomach muscles, and then bear down. And I'll do it with them and practice a few times. I'll practice with them and run my spectrum to make sure that they are doing it, that it works, that it's effective. And I also do it without pulse wave. I use it with just color. I have the patient perform a Valsalva watching the color. What's happening with the color flow pattern? Is there an area of reflex that I need to document? So color is, again, it's a great tool to map out our anatomy, but also helps to localize spots of disease, area of disease. So for our patients that have a hard time with following the breathing instructions, we can have them plug their nose and close their lips and blow. That will increase the venous intraluminal pressure. We can also have their patients on the table, have our patient just lift their head as she's doing there. That will also increase that pressure and hopefully stress the valves enough to stop the blood flow so that we can see if they are competent. But it's really definitely important to practice with our patients to coach them through it. We should always start our exams explaining to the patient what we're doing, ask why they're here, of course verify who they are with 2 forms of ID, but then throughout the exam, talk to them about what we're doing and why we're doing it. And they want to help. They will help. We just have to explain what we need them to do. And a Valsalva maneuver isn't easy. It can be difficult for them. When this is in the groin here, this would be the saphenous into the common femoral vein, and there's our arterial bifurcation there. So this would be the first location that we are evaluating the deep system as well as the superficial system for reflex. We are, gotta move this here. We're doing, there's 2 different schools of thought. In preparing for this lecture, I read a couple of different ideas about how to get the best response for reflux. Here, of course, is our typical sagittal image where the saphenous vein is draining into the common femoral vein. There's a couple of valves in this area that are very important to evaluate. We have the terminal valve here, the saphenous vein draining into the common femoral, and then downstream a bit, there's the pre-terminal valve. So we really want to walk our sample gate through this area as the patients are practicing their maneuver, the Valsalva maneuver. either you're watching it with color or you're walking it through with your Doppler so that you can really assess that area for venous incompetency. It isn't the type of study where we just take one measurement, say as we do with the carotids, of proximal common carotid artery, we take our waveform and our measurement and we move on with the protocol. With this type of testing, we have to take a little bit more time and really walk our sample gate through, observe with color and pulse wave to make sure we really are getting the information we need for our patients to demonstrate the reflex. This window here, this view here is more in line with the blood flow per some literature out there, where you're actually assessing the blood flow as it drains into the common femoral vein. I'm going to try it the next time I do a study. Supposedly this approach here is actually more sensitive to detecting venous reflex. Personally, I've always done this and had great success, but this is supposed to be even more successful. So I look forward to trying it. But this is where the thought process is that it is traveling in with the blood flow. You're angling with the actual direction of the blood flow, where this is not. In those cases where the patient cannot perform a Valsalva maneuver at all, you've done your tips and they still can't, they can't do it, you can't get elicit the response that we need to get, we can perform a proximal compression. Here is demonstrating proximal compression with the probe more down into the middle of the thigh, but this will also work in the groin. If the patient cannot perform the Valsalva maneuver, you could just press into the pelvis area or even onto the abdomen, press down to create, increase that venous intraluminal pressure and hopefully stress the valve so that we can test them. The proximal compression is a very useful tool to evaluate these veins that are farther down into the leg, deeper, or like the femoral vein and the popliteal vein. And then also distal augmentation or slow augmentation. I think this method is great. This is what I really prefer to do more than proximal compression, is just a real slow augmentation distal to the probe. It increases your blood volume traveling through. You have that nice augmentation, and then you demonstrate the reflex after the augmentation. And this works really, really well in assessing the saphenous vein. These are just some different waveforms demonstrating what the reflex will look like. And again, this would be with slow augmentation, and then we've got the reflex, the prolonged reflex. When we are measuring our reflex, we have to actually quantify it. We can't just say there's reflex with color or I saw reflex on the spectrum. I have to measure it. We have to give it a number. And we're measuring time. We're measuring the duration of reflex. Most of our velocity measurements are peak systolic velocity. Most of our measurements seem to be with Doppler. But this is actually time. So when you're using your system, you have to change how you're using those calibers. You have to actually go into your package and select time or whatever. All the vendors are a little bit different, but just that you're measuring time, not peak systolic velocity. And then finally, to talk a little bit about those perforators. These perforators can cause problems for our patients, especially through the gator zone. They in several research studies, they have been linked to ulcers, and treating these incompetent perforators have been said to also help heal the ulcers. So localizing these perforators and determining whether they're incompetent or not, especially in the patients that are suffering from venous ulcers, are very important. Recall the perforator is a communicating vein or a bridge vein from the superficial system to the deep system, allowing blood to flow in one direction. There are valves. There's valves in the perforators, there's valves in our deep system, and valves in our superficial system. When the perforators are incompetent, they're pretty easy to see. They're very obvious, they're very dilated, and we typically want to measure the diameter of those perforators at the fascia, at the level of the fascia there. and we can measure the diameter, and we also can assess the blood flow to determine if there is reflux. And then for some of our, depending on what the test is for, if it's for treatment or if it's a wound care patient that you're following for venous insufficiency and ulcers, you might actually need to map out the location of the perforator so that they can be treated. And usually the medial malleolus is our reference point to map those perforators. And we consider either our probe, the length of our probe as a measurement tool, use possibly a ruler, or even consider our screen and the depth, and just estimate where that perforator is in relation to the medial malleolus. And on our worksheet or whatever tool you use to document your findings, you would note that incompetent perforator 5 centimeters proximal to medial malleolus. And we would evaluate, we typically start at the medial malleolus, looking at the using the posterior tibial vein as a landmark, and then start following and flashing as you're scanning, ascending the calf, searching for incompetent perforators, and looking at the superficial system and the deep system, and what's connecting, and what's enlarged, what appears normal. When abnormal, they are very, when dilated and incompetent, they're very easy to see. Typically on your annotation, you could label it Cockett perforator, or you could just say perforator 1, perforator 2, perforator 1, 2 centimeters proximal to medial malleolus, perforator 3 is 6 centimeters, and then draw them on your worksheet and note it as well. So our diagnostic criteria for the evaluation of reflux in our deep veins, if it's greater than a second, it's considered reflux insufficient, the valvular insufficiency. And then within the greater saphenous vein and the short saphenous vein, if the reflux is greater than 0.5 seconds, it's considered abnormal. And then in the perforating veins, if it's greater than 0.35 seconds, it's considered abnormal. That's the criteria that we're using. Probably the most important aspect of this study is to really look at your patient. You really look at their legs, make sure, you know, our veins, we have our protocol, we know our anatomy, we're looking at the deep system, we know the saphenous system is medial, we know where the perforators are, we know there's tributaries and some accessory veins, but some of these veins, they can develop all over the leg, and it would be outside of our normal scan area. So we really need to look at the patient's leg, talk to them about their symptoms. Where does it hurt? Where do you feel the congestion or the heaviness or that vein? I can palpate this vein or this mass. We have to ask them and have them point to it. You know, we could run through our entire protocol for a deep system and superficial system, and it's normal, but the area of complaint is lateral leg. And when we look there and the patient shows us what's bothering them, we see a large varicosity, and we assess it and follow it and determine where it goes. But if we wouldn't have looked or asked, we would have missed it because it was on the lateral leg, and we are not scanning the lateral leg. We scan from the medial and anterior approach typically. So it's really important that we are talking to our patients and asking them where it hurts, look at their veins, you know, look at the ulcers. And we're fortunate because we can move our probe, our camera, and wherever it needs to go.